Could I ask the panelists for the first session to come up, please, and have a seat here at the table. And please join me in welcoming from the great state of San Francisco, Amanda Reiman.
Thank you. I'm very excited to be here today. I'm really happy to be able to come and talk to you. And one of the reasons I'm really happy is that I'm actually not talking about something so controversial this morning. So my name is Amanda Reiman, and I am the policy manager for the state of California for the Drug Policy Alliance. But prior to that, I was a public health researcher looking at marijuana use among medical marijuana patients and also looking at marijuana as a substitute for alcohol and other prescription drugs. So in terms of conflict of interest, I would say that our organization definitely advocates for the reform of marijuana laws across the country. Our goal is to find marijuana regulations that protect public or individual autonomy while still protecting public health and safety. So that's kind of our goal. So I'm looking for my slides. Here we go. So I'm here today to talk to you guys about what is marijuana. So, there's an assumption that, now that marijuana is legal in Colorado, that individuals automatically know about the plant and its constituents and the chemicals that are inside it, and we know that that's absolutely not true. So I think it's really important before we hear from the other presenters today about some of the health impacts of marijuana, some of the policies related to marijuana use, that we first take a step back and look at what is this plant? Where did it come from? How are the different ways that people use marijuana? And hopefully this will provide a context for the rest of the program today. So I'm going to give just a very brief overview of the history of marijuana policy, a look at the plant itself. THC is the chemical we hear a lot about, although CBD is also starting to make waves, so I'm going to talk a little bit about what those chemicals are, a bit about our endocannabinoid system, which I think is really important because we have a body system that releases chemicals that are identical to the cannabinoids found in the plant, and that really is a big key to how marijuana works within our bodies. And then I'll talk a little bit about how people are using cannabis. And I always joke about this part, that it's not actually how to use cannabis, but given that we're in Colorado, it kind of could be how to use cannabis. And then we'll have some time for questions. So when we look at cannabis or marijuana, and by the way, I want to make the disclaimer that they're the same thing. I kind of assume that people know that, but a few years ago, I was giving a talk to about 400 undergrads at Berkeley, who I really assumed would know that. And after saying the word cannabis for about the first 10 minutes, someone raised their hand and said, "Is that the same thing as marijuana?" So yes, I use the words interchangeably. Cannabis is really the traditional name. So before marijuana became illegal in the United States in 1937, it was cannabis. It was found in a lot of medicines. Marijuana was the term that Mexican immigrants had given to the plant. And so when they brought it into the United States in the early 1930s, marijuana was the word that was used to describe the plant that they had. So references to the therapeutic use of cannabis actually date back to 2800 BC. So, when we pass medical marijuana laws or marijuana laws and we start talking about what does this mean for use and what does this mean for individuals in the human body, I think it's important to remember that this is actually one of the oldest plants in existence. So this is something that individuals across cultures, across the world, have been using for various purposes for really a very, very long time. It was introduced to the U.S. Pharmacopoeia in 1854, but then we had something happen in the early 1930s, which is that there was an influx of Mexican folks immigrating up from Mexico into the United States and bringing marijuana with them. The folks that were already living here were a little concerned. Here we had a new population of people with a different language and a different culture who were coming into the United States with this new intoxicant that even though was available in a lot of patent medicines in the United States. They were smoking it, and that was very different. And so the Marijuana Tax Act was passed in 1937 largely as a way to control the new population of immigration. It was a way to stop people if they were using marijuana, to search them, to detain them. So I think it's important to think about in this context that the very beginning of marijuana prohibition wasn't so much about the marijuana plant, it was beliefs about the individuals that were using the marijuana plant. So I just want to put that out there. And then it was removed from the physician's desk reference in 1942. So to give us an idea around a timeline, now this is not to scale, but if you look at 3000 BC, when we had the first kind of recollection or information about marijuana being used in different cultures, most likely medicinally, it was a medicine until 1937. And its history as an illicit recreational drug is really quite short compared to its history as a therapeutic agent. So its history as only being an illicit recreational drug is really from 1937 to 1996, when California became the first state to recognize the therapeutic use of cannabis. So I think, again, we act sometimes as if marijuana is this brand new thing that's just coming on the scene, when the truth is it's actually been here for quite a long time. It's just how we're framing it and how we're regulating it that's starting to change. So what is cannabis? Well, when we talk about cannabis or marijuana, we're talking about the dried flower tops of the cannabis plant. So the marijuana buds are basically the flower. It's the flower that's produced by this plant. There are 3 varieties of cannabis. There's indica, sativa, and ruderalis. Ruderalis is what we commonly know as industrial hemp. So ruderalis does not have the psychoactive components that the sativa and indica varieties of cannabis do. Now, in the Bay Area, where we have a very robust medical program with lots of dispensaries, we see the marijuana being categorized as indica or sativa. You guys probably see that out here as well, either in the recreational stores or in the medical dispensaries. That is kind of a cultural phenomenon, and to be honest, it doesn't really hold much weight anymore. There used to be a time way back in history, thousands of years ago, when there were very distinct differences between an indica variety and a sativa variety of cannabis. But over the thousands of years of crossbreeding, what we really have today is a whole bunch of hybrids. So when people really talk about, oh, well, sativa is the up feeling and indica is the relaxed feeling, that's all really subjective. What we're really talking about is a whole number of strains, over hundreds and hundreds of strains, that are a mix of kind of these ancient varieties of cannabis. Cannabis contains over 600 chemicals in that little plant. About 70 of them are considered cannabinoids, or what we would call the active ingredients. The others are terpenoids, which I'll talk more about in a minute, and non-psychoactive chemicals that were related to plant growth and photosynthesis and those kinds of things. So the main chemical components of cannabis is the rock star, THC. So that's the one we talk all about, right? That's the psychoactive one. That's the one that people are concerned that there's rising amounts of THC in cannabis. I mean, the truth is we've always had a variety of strengths of cannabis. We've always had cannabis that's very low in THC, cannabis that's very high in THC. But as you can imagine, when you have an illicit market, there's certain types of cannabis that become more popular. And those are the ones with the higher THC. Because if I'm going to go take a legal risk and buy marijuana on the illicit market from somebody I don't know, where I could possibly go to jail, I kind of want the biggest bang for my buck. I want to go out there, and I don't want the Miller Lite. I want the moonshine because I'm taking a risk, right? And so I think that when we see rising levels of THC in cannabis, a lot of that is because of prohibition. When we had alcohol prohibition, the alcohol that was available was much stronger because of the same reasons. So now in California, something that's really interesting is that when I go into dispensaries and we have the cannabis labeled of how much THC is in it, the majority of people that I observe are not gravitating towards that 20% THC. They're actually looking for something between the 9 and 12% range. So having that option, I think, is something that comes with regulation. Then we have the silent hero, CBD. So CBD's gotten a lot of press lately, primarily around the implications for its therapeutic use for childhood epilepsy. CBD is a really interesting chemical because it does have a lot of therapeutic properties, and I'm not going to say it's completely non-psychoactive, but it's psychoactive in a different way than THC. THC, you might refer to the effect as more mind-altering, whereas CBD is more sedative. Kind of like if you were taking a Valium or something like that. But CBD has a lot of therapeutic potential. What we're starting to see in some states is the passage of medical marijuana laws that are CBD only. And that also has a concern because of some of the therapeutic benefits of THC. But I think that CBD is one of the cannabinoids we're going to hear a lot more about in the future. And if you go into a marijuana store, they already have products that are CBD-only products that are very, very low in THC. Then we have the goofy sidekicks who never really star but are waiting for their big break and just might get it. And these are these other cannabinoids: CBN, CBG, THCV, THCA, CBDA. And these, in the current marijuana products that we have, are available in very, very small amounts. So when you test your typical strain of marijuana at a dispensary, it's primarily going to come back with THC, maybe a little bit of CBD if it's been bred that way, and then very, very, very trace amounts of these other cannabinoids. But something that's very interesting is that research shows that even though these cannabinoids are only there in very trace amounts, that they do play an important role to the overall effect, something that we refer to as the entourage effect. So it's kind of like that Gestalt theory of the sum being greater than the whole of the parts, and that's what the cannabis plant is. And that's one of the reasons why research on whole plant medicine, rather than just the individual constituents of the plant, many times which are synthetic versions of the real thing, is so important. So for example, THCV has been shown to suppress appetite, where THC has been shown to stimulate appetite. THCA and CBDA are the acid forms of these cannabinoids. So something you may not know, when you have a raw marijuana plant, it's non-psychoactive for the most part. In order for those cannabinoids to become psychoactive, they have to be heated. So if you have a plant, a little bit heat has been applied to it through the sun or light source, but not enough to truly convert all of those acid cannabinoids to the decarboxylated psychoactive version of cannabinoids. So I know that that's a whole lot of wonky sciencey stuff, but what it basically means is that if you have a tincture that's just THC acid or CBD acid, it's non-psychoactive. So individuals who juice the raw plant to get the benefits of the different cannabinoids in there are not getting the high like somebody that's lighting the plant and then inhaling the heated version. And then the backup dancers, which are the terpenoids, or the smells. So let's talk a little bit about that. So, I have been doing research in dispensaries for years before I started doing policy work. And I've probably spent, thousands of hours sitting in dispensaries observing medical marijuana patients and talking to them. And something that was really fascinating when I first started doing this, which was like 2002, is that they had a little note at the front of the counter that said, "Please do not stick the buds up your nose." And I was just from Chicago. I had just moved to the Bay Area. And I was like, what are they doing with marijuana out here? How are they ingesting it? Are they chopping it up and snorting it? I was just flabbergasted. And then I sat and watched folks for a while and saw that pretty much every patient that came up wanted to smell the marijuana when making the decision about which they were going to purchase. And I found that really interesting. So I started, looking into what the smells are. And they're the terpenoids. So many people smell their cannabis when deciding which strain to purchase. Terpenoids are found in everything. So why does an orange smell like an orange? Why does a pine tree smell like a pine tree? It's because of the terpenoids. It's because of the smells inside the plant. So terpenes have therapeutic benefits as well. We can think about lavender, lemon being used in aromatherapy. So there's actually an aspect of cannabis besides just these psychoactive cannabinoids that also adds to the overall effect. And that is the terpenoids, or the smells. So now I want to talk a little bit about the endocannabinoid system. So the endocannabinoid system is responsible for maintaining homeostasis or balance in our bodies. When something is dysregulated, it is the endocannabinoid system that kicks in for regulation. It's actually the very first system that forms once the egg is fertilized. We have endocannabinoid receptors in our gut, in our brain, in our eyes, pretty much all throughout our bodies. The endocannabinoid system, like I said, it regulates things like pleasure, pain, sleep, appetite, sex, metabolism. I mean, really important things. The endocannabinoid receptors in our bodies are like keyholes, waiting for that endocannabinoid to come and fit just right, and that provides the effect. When you introduce phytocannabinoids, or the cannabinoids from the plant, they mimic the endocannabinoids that our bodies produce, and they fit right in that keyhole, which explains some things about not only the effects of cannabis, but the unlikelihood of overdose from cannabis as well. Now, some research that's just starting, which I think is really fascinating. By the way, we didn't know we had an endocannabinoid system till the mid-90s. Just throwing that out there. So this isn't something we've been studying for a very, very long time. This is actually a fairly recent development. And something else we're starting to look at now is the possibility that some people might have endocannabinoid deficiency, and that deficiency may be responsible for some diseases of dysregulation, such as cancer. Even water can be fatal. So this is my cautionary tale. So even though cannabis cannot be fatal, cannabis does impact our brains. And that's not without risk. We're going to hear today about issues related to dependence, mental illness, the developing brain. These are all extremely important. And even though I and my organization do support marijuana law reform, we absolutely think that these are very important issues that need to be worked into any type of regulatory program. So the last thing I want to say before we open it up for questions are just some ways to ingest cannabis. So there's basically 3 ways. There's inhalation, which is smoking or vaporizing. There's eating, which could be edibles, tincture, and then there's rubbing it on the skin through topicals. Some basic things to know about methods of ingestion. Topicals are non-psychoactive. They're fabulous for older individuals that have localized pain. The same product, same method of ingestion can affect a person differently at different times. Eating cannabis is not the same as smoking cannabis, which is a whole other lecture. Smoking cannabis is not the same as smoking tobacco, even though there are some similarities in that method of ingestion. And it's what's in the strain that matters, so don't get hung up on the name. There's a lot of strain names out there that they're historical. You know, we've had some of these strains for 40, 50, 60 years. But now that we're starting to test the cannabis, it's not so much about the nomenclature anymore as it is about these plant constituencies, the cannabinoids, the terpenoids. And that's really what we need to be focused on. All right. That's it for me. Thank you.
Any questions from the panel? Let me just ask a quick question because I can't help myself. So we're going to hear a lot of research today summarized. Is the research that's been done in the past relevant to today's marijuana?
Yes and no. Marijuana has been around for a very, very long time. The plant itself really hasn't changed that much. However, I think that looking at a substance from a public health perspective versus a prevention perspective is very different. So studying marijuana as we study heroin or cocaine as terms of problematic use, prevention, how do we keep it out of the hands of people, is very different than how we study alcohol, which is how do we help people use it safely, how do we regulate it in a way that only certain people have access. So I think that's the main difference.
Specifically, my question, though, is about strength. And what I hear is that today's marijuana is different than yesterday's marijuana. So can we really apply the research evidence to the product that is being sold today?
Well, one problem is that the previous research, we have no idea how strong that marijuana is because that's not part of the research, just to look at. So I would say we don't really know what the baseline is.
Okay.
The research we're doing now, we can actually look and say, okay, they were using a 19% THC strain or a 23% THC strain. But previously it's been, have you used marijuana, yes or no? How often have you used marijuana? How much are you using? Without necessarily looking into these chemical constituents.
Thank you. Other questions from the panelists? Anybody?
They all know a lot about marijuana.
No, they don't. Anything else about the product? David?
I'll step out there with a question. You said that it needs to be heated in order to activate the acid forms. So within the ingestible forms, Can you talk a little bit more about the ways in which people are ingesting and heating to activate the acid forms?
Absolutely. So through inhalation, it's pretty self-explanatory. You're either lighting it with fire or through vaporization, you're heating the plant material to a temperature that releases those active ingredients and converts the acids to the decarboxylated, but doesn't burn the rest of the plant material. And that's why vaporization is so health conscious, because it doesn't actually burn any organic matter, but it does heat it just enough to decarboxylate those acid cannabinoids into the decarboxylated forms. In terms of the edibles, it has to be heated at some process when they're making that. So it might be through the process of making the butter. It could be heated, or through making the oil that the cannabis is used, or even baking. So, if you take cannabis, you grind it up and you put it in brownies, you have to bake it in order for that cannabis to activate. You can't just, eat a bunch of raw cannabis and have it be activated. And then in terms of the topicals, they are non-psychoactive. So, rubbing something on the skin, even if it has a decarboxylated THC, it doesn't break the brain barrier in a way that causes psychoactivity to happen. It's more of a localized, I call it organic Bengay. So we're really talking more about the oral and the inhalation versions that are decarboxylated, either through actual lighting of fire or through the process of processing the product.
Thank you very much.